Welcome back to the deep dive. Imagine this scenario. You're facing a patient with severe, life-threatening anemia. Their oxygen delivery is failing, tissues are starving for oxygen, and, well, every moment counts.
Uh-huh. Critical situation.
But the most immediate conventional lifeline, a blood transfusion, is just not an option. Maybe it's the patient's deeply held religious belief, maybe it's a complex antibody issue making cross-matching impossible, or simply that blood isn't readily available right now.
Right. These aren't just theoretical problems, they happen.
Exactly. This isn't a theoretical exercise. It's a really high-stakes clinical puzzle you might face, and it demands some alternative thinking.
And that's precisely where we're plunging in today. This deep dive, built specifically from the stack of expert sources you've provided, is all about navigating that critical challenge, managing severe anemia when transfusion is off the table.
We're going to dissect the fundamental physiological problem. Inadequate oxygen delivery in this specific context. We'll explore why traditional transfusion-based management isn't always the straightforward answer we wish it were, looking at its limitations, potential complications.
Yeah, the downsides. And then we'll take a really detailed look at a therapy that's, well, it's been around for a while, it's well established, but perhaps isn't always the first thing that comes to mind in this acute setting. Hyperbaric Oxygen Therapy, or HBOT.
Oh, right.
We'll examine its physiological basis, exactly how it gets oxygen to tissues when red blood cells can't review the evidence supporting its use from, some pretty compelling animal studies to human clinical experience, and get into the practical considerations for applying it when the clock is ticking.
Okay, so we'll cover the key formulas, the critical thresholds, a bit of historical context, and the latest evidence discussed in the material. Think of this as your shortcut to understanding the core problem and a powerful potential solution designed for you, the clinician needing to make rapid decisions in a crisis.
Our goal here is to provide the critical analysis and the clinical context, helping you connect the dots and see how this approach fits into your decision-making process when faced with this incredibly difficult situation. So let's get started.
Okay, let's unpack the core problem first. Defining what severe anemia means in this critical context. The material starts by describing it simply as a marked loss of red blood cell mass.
Right, and this loss, as the sources detail, can happen for a few main reasons you'll see in practice. Acute hemorrhage, whether that's external, internal surgical bleeding, or hemolysis, where red blood cells are just destroyed rapidly within the body, or even aplasia, a failure of the bone marrow to produce enough red blood cells in the first place.
But the danger, the life-threatening aspect, isn't just the low number of red blood cells, is it? It's the direct functional consequence.
Exactly. It's the inadequate oxygen carrying capacity by the blood. The red blood cells, specifically the hemoglobin molecule they contain, are like, well, tiny delivery trucks for oxygen. When you don't have enough trucks, you just can't deliver enough oxygen. Simple as that, really.
And critically, the sources emphasize the temporal aspect. How quickly this severe anemia develops is a major factor in how well a patient can tolerate it.
That's a huge point. A patient who becomes anemic slowly, say over weeks or months, often develops compensatory mechanisms. Their body has some time to adjust.
Right.
But a patient who acutely hemorrhages, loses blood volume and red cells rapidly over minutes or hours, they have minimal time to compensate. Their system is just overwhelmed, and they are far less tolerant to that loss of oxygen carrying capacity.
And that acute setting is precisely where the danger lies. That's where we see the crisis. So let's delve into the physiology of oxygen transport to understand this better. Hemoglobin is presented as the primary oxygen carrier. The material gives us a fundamental number. 1 gram of hemoglobin can carry up to 1.38 milliliters of oxygen when fully saturated.
That number, 1.38 milliliters per gram of HB.
Yeah,
that's your anchor for understanding the carrying capacity bound to red cells. It's the main event, usually. But the sources are careful to point out that there's another way oxygen travels in the blood. A smaller way, typically.
Dissolved directly in the plasma.
Exactly. Dissolved oxygen, the material provides the value. 0.0033 milliliters of oxygen per millimeter of mercury, of the partial pressure of oxygen in the inhaled gas per milliliter of plasma.
Okay, 0.003. So at normal atmospheric pressure, breathing room air, or even supplemental oxygen by mask, this dissolved component is usually quite small.
Very small. Relatively insignificant compared to the oxygen bound to hemoglobin under normal conditions. You can think of the hemoglobin-bound oxygen as like the large, dedicated cargo ship carrying the vast majority of the oxygen. Well, the dissolved oxygen is like a small sprinkling of oxygen molecules just floating freely in the bloodstream, doing very little heavy lifting.
Normally.
Normally. Okay. This brings us to the crucial formula for arterial oxygen content, or CaOO. It's the sum of these two components, right? The oxygen bound to hemoglobin and the oxygen dissolved in plasma.
That's it. Conceptually, as the sources explain, it's the amount of oxygen loaded onto the cargo ships plus the amount sprinkled in the water they're sailing through.
I like that analogy. It makes it memorable.
More formally, the formula is presented as CaO arrows equals brackets. Grams of hemoglobin per deciliter multiplied by 1.38 milliliters of oxygen per gram of hemoglobin multiplied by the fraction of oxygen bound to hemoglobin, which is usually close to 1 or 100% in arterial blood. Close brackets, PLUS brackets, 0.003 milliliters multiplied by the partial pressure of oxygen in arterial blood in millimeters of mercury.
Okay, so the first part of the formula is a cargo ship component, how much hemoglobin you have, how much each gram can carry, and how full those ships are, essentially. Right. Your HB level, the 1.38 constant, and the O2 saturation.
And the second part is the sprinkling component, how much oxygen is dissolved, which is driven by the partial pressure of oxygen in the arterial blood, the PaO.
Precisely. And knowing these two components is absolutely foundational to understanding oxygen transport and how different therapies might influence it, especially, as we'll see, hyperbaric oxygen.
Okay, let's pause here for a moment. Quick recall for everyone listening. Base of the material. Can you quickly recall the two primary ways oxygen is carried in the blood?
Short pause.
Oh.
Okay, so it's carried bound to hemoglobin within red blood cells. That's the main way. And then it's also dissolved directly in the blood plasma.
Perfect. Got it. Now, having oxygen in the blood isn't enough. It has to actually get to the tissues that need it. This leads us to the formula for oxygen delivery, or DOOs. The sources give us this as DORO equals cardiac output multiplied by the arterial oxygen content, COO.
Yeah, delivery, flow X content. It tells us that oxygen delivery is a function of two things. The pump, how much blood the heart is moving per minute, the cardiac output, and the content, how much oxygen is in each unit of that blood, the CIO.
So in severe anemia, the CIO is low because the hemoglobin is low. We know that. The body's initial compensation is often to increase the cardiac output, try to pump the limited oxygen-poor blood faster to maintain overall delivery.
Right. The heart tries to work harder. But as you mentioned, there's a limit to that compensation, especially in sick or injured patients. The heart might already be stressed or just can't keep up.
And if the heart can't pump fast enough to overcome the low CIO, the oxygen delivery, the DOO, falls below what the tissues demand.
And the tissue demand for oxygen is captured by the oxygen consumption, or VOO. The sources refer to the Fick equation for VOO, which is VOO equals cardiac output multiplied by the difference between arterial oxygen content, CIO, and mixed venous oxygen content, CVO.
Okay, so CVOs is the oxygen left in the blood after it's passed through the tissues and returned to the right side of the heart. So that term, CaO minus CVO, represents the arteriovenous oxygen difference. It's how much oxygen the tissues have actually extracted from the blood as it flowed by.
Exactly. This equation shows that oxygen consumption, what the tissues actually use, is the product of flow, cardiac output, and extraction, the AVO-EURA difference. Tissues will extract oxygen based on their metabolic needs at that moment.
And the sources state that typically the body extracts about 5 to 6 milliliters of oxygen for every 100 milliliters of blood that flows through most capillary beds. Is that right?
That's the average extraction rate mentioned, yeah. 5 to 6 milliliters per deciliter of blood flow.
At normal hemoglobin levels, delivering that 5 to 6 milliliters per 100 milliliters is easy, no problem.
Right. Plenty of reserve capacity.
But as hemoglobin drops significantly, the amount of oxygen delivered per 100 milliliters falls, making it much harder for tissues to get what they need, even if they try to extract a larger percentage of what little oxygen is delivered.
And that's where we hit critical thresholds. The sources provide specific hemoglobin thresholds where oxygen delivery becomes problematic or clearly inadequate. They say oxygen delivery becomes problematic when hemoglobin drops to 6 grams per deciliter.
6 grams per deciliter. Okay, that's the warning zone?
You could think of it that way.
Yeah.
And then it gets worse. Delivery is considered clearly inadequate at hemoglobin levels below 3.6 grams per deciliter.
Below 3.6. That's incredibly low. Those are absolute red flags you need to be aware of clinically.
Definitely. Maybe you remember 6 GDL as needing 6 extra checks on oxygenation. And 3.6 GDL, well, you're getting perilously close to needing 3 6 feet under, to put it grimly. It emphasizes the extreme danger.
Okay, good mnemonics. So when oxygen delivery consistently falls short of the tissue's needs over time, the patient develops what the sources call an accumulative oxygen debt.
Right, and they define it precisely. It's the time integral of the oxygen consumption measured during and after a shock insult, minus the baseline oxygen consumption required during that same time interval.
Okay, let's unpack that a bit. Time integral means summing it up over time.
Essentially, yes. In simpler terms, it's the total deficit between the amount of oxygen the body's cells needed to function normally during a period of stress or shock, and the total amount of oxygen they actually received over that same time. That unmet need accumulates like a debt that the body owes itself.
And the sources highlight clinical research that has quantified the critical thresholds for this accumulative oxygen debt, specifically in patients who suffered severe hemorrhage, looking at the first 4 hours. The numbers are stark and critically important for understanding prognosis.
They really are. If the accumulative oxygen debt exceeds 33 liters per square meter of body surface area,
33 LM-ACOP.
the research shows there is effectively no chance of survival. It's described as a point of no return.
Wow. Okay. And the next threshold?
If the debt exceeds 22 liters per square meter, multi-organ failure or MOF occurs. Survival might be possible, but you're looking at significant damage and complications.
22 LM-AC means MOF. Got it. And the lower end?
Conversely, if the accumulated oxygen debt can be kept below 9 liters per square meter within that crucial early period.
Below 9 LM and Aramin.
Most patients in similar circumstances survive without residual disability.
So these thresholds really define different zones of risk. Below 9 is relatively safe. 9 to 22 is the danger zone for multi-organ failure. And above 33 is the lethal zone. Understanding these numbers really underscores the urgency of restoring oxygen delivery quickly.
Absolutely. It quantifies the consequences of delay.
Let's check back in. Quick board-style question for you listening. Can you recall the 3 critical thresholds for accumulated oxygen debt mentioned in the sources and an outcome associated with each within the first 4 hours of severe hemorrhage?
Short pause.
Oh.
Okay. Hopefully you recalled. 9 liters per square meter is associated with survival, usually without disability. 22 liters per square meter is linked to multi-organ failure. And 33 liters per square meter means basically no chance of survival.
Excellent. Those numbers are deeply impactful when you're managing a patient in shock from severe anemia. Okay, micro recap 1. So far, we've established the core problem: severe anemia as a marked loss of red cell mass leading to inadequate oxygen carrying capacity. We've explored the fundamental physiology, outlining the 2 ways oxygen is carried hemoglobin-bound and dissolved via the CIO formula. We looked at how oxygen delivery, DO, depends on cardiac output and CIO, and how oxygen consumption, V arrows, relates to flow and tissue extraction.
Right, the basics of O2 transport.
We've noted the critical hemoglobin thresholds of 6 and 3.6 grams per deciliter, where oxygen delivery becomes problematic or inadequate.
Key numbers.
And we've defined accumulated oxygen debt and presented the grim clinical thresholds of 9, 22, and 33 liters per square meter, linking them directly to survival and multi-organ failure. This really sets the stage for understanding the dire consequences when the body cannot meet its oxygen demands.
Exactly.
Yeah.
It highlights the physiological cliff edge we're dealing with. Now, given that critical situation, the immediate go-to therapy is typically a red blood cell transfusion.
Right, that's standard practice.
But as we highlighted at the start, this isn't always possible. And the sources spend some time detailing the significant circumstances that might prevent conventional transfusion in severe anemia.
One prominent reason mentioned is when a patient refuses blood products based on religious grounds, like Jehovah's Witnesses or strong personal preference. This is a significant factor you absolutely must respect, and it immediately necessitates alternative strategies.
Absolutely. Patient autonomy is paramount. Another reason can be technical or medical. The patient simply cannot be cross-matched to receive blood. Maybe they have complex or rare antibodies, making it impossible to find compatible donor blood safely and quickly, especially in an emergency.
That's a tough spot.
It really is. Then there are concerns regarding transfusion-transmitted infection, or TTI. The sources acknowledge that modern testing, like nucleic acid testing or NAT, has dramatically reduced the statistical likelihood of transmitting major infections like HIV, HEV, Zika, West Nile, even SARS-CoV-2 virus. The risks are quoted as approaching 1 per 2 million units transfused for many of these. Extremely low risk.
Almost negligible.
Statistically, yes. But the sources note that this residual risk, however small, can still prompt patients to exercise their right to refuse transfusion. They may just not want to take any risk, however small.
Understandable. Beyond infection risk, the sources point out that avoiding potential complications from emergency blood transfusions is another reason to consider bridge therapies.
Right.
Using uncross-matched or type-specific blood in a true crisis.
Right. Emergency release blood, while potentially life-saving, carries some inherent risks compared to fully cross-matched units. And then there are the specific dangers associated with massive transfusion therapy, which might be required to treat life-threatening anemia with blood alone.
Massive transfusion complications. Yeah, the sources list several, like transfusion-related acute lung injury, TRALI.
TRALA, yes. Acute respiratory distress right after transfusion. Very serious. There's also transfusion-associated dyspnea, or TAD, just difficulty breathing, related to the transfusion.
TRALI and TACO.
Transfusion-associated circulatory overload, TACO. That's where the volume of transfused fluid overwhelms the patient's circulation, basically causing fluid overload and heart failure symptoms.
And the sources even mention the potential for yet unknown pathophysiology associated with giving very large volumes of blood transfusions. Sort of a catch-all for things we might not fully understand yet.
Yeah, it acknowledges there might be other subtle or unrecognized effects. And finally, the sources highlight the potential for untoward inflammatory and immunomodulatory effects from large red blood cell transfusions.
Immunomodulatory, meaning it affects the immune system.
Exactly. Transfused blood is essentially a tissue transplant from another person. It's foreign tissue. And like any transplant, it can trigger immune responses that may have negative consequences, perhaps increasing infection risk later or causing other inflammatory issues.
Okay, so facing life-threatening anemia with any of these hurdles to transfusion refusal, incompatibility, infection fears, or worries about massive transfusion effects, that's a daunting clinical situation. It demands creative and effective alternative approaches to maintain oxygen delivery.
It really does. Which leads us to exploring those alternatives. One type explored in the sources is blood substitutes.
Ah, yes. What do they mention specifically?
They specifically mention perfluorocarbons and cell wall-free polymerized hemoglobin as examples of agents designed to carry oxygen in the absence of red blood cells. Basically artificial oxygen carriers.
Sounds useful. Are they available?
Well, the sources are clear about their current status. Both are still undergoing randomized clinical trials, and neither has yet received final Food and Drug Administration approval for routine clinical uses in the U.S.
Ah, so promising for the future, maybe, but not currently widely available or approved options for this scenario.
Not yet, no. Interestingly, though, the sources mention that both of these blood substitute approaches are still compatible with hyperbaric oxygen therapy. So potentially, they could be used in combination in the future if approved.
Interesting. But for now.
For now, this brings us to the main alternative discussed in detail in these sources, hyperbaric oxygen therapy. HBO is explicitly presented as a bridge therapy in the treatment of acute severe anemia when transfusion is not possible.
A bridge therapy. And its specific role as a bridge is precisely to avoid those potential complications we just listed. TRALI, TACO, immunomodulation that can arise from emergency and massive transfusions.
Exactly. It buys time safely. It's also important to note that according to the sources, HBO for severe anemia has had a long-standing approval for use by the Centers for Medicare and Medicaid Services, CMS, and its predecessor agency, HCFA.
So it's not considered experimental in this context from a regulatory or payment standpoint.
Correct. It's an established, approved indication.
Okay. Micro recap 2. We've laid out the significant clinical situations where red blood cell transfusion might not be possible for severe anemia, patient refusal for religious or personal reasons, inability to cross-match, concerns about transfusion-transmitted infections despite low risk, and importantly, the significant potential complications associated with emergency and massive transfusions, including TRALI, TAD, TACO, and immunomodulatory effects.
Right, a whole list of challenges.
We touched on blood substitutes like perfluorocarbons and polymerized HB as potential future alternatives currently in trials, but not yet FDA approved for routine use.
Still on the horizon.
And we introduced hyperbaric oxygen therapy as an established CMS-approved bridge therapy specifically highlighted for its ability to avoid those transfusion-related dangers.
Okay, so now that we understand the challenge and the need for alternatives, let's dive into how hyperbaric oxygen therapy actually works to address inadequate oxygen delivery in a severely anemic patient. This brings us right back to that arterial oxygen content formula, the CAO.
Right, the formula again. COA-OBRAM. HGBDL, 1.38 milliliter O6BOX, fraction OHB, plus 1.0003 milliliter X millimeter HGPO. In severe anemia, the first part, the hemoglobin-bound oxygen, is drastically reduced because the grams of hemoglobin per deciliter is very low.
Exactly. Now, under normal atmospheric pressure, even breathing 100% oxygen, You can maximize the saturation, the fraction OHP part, and you can increase the payloads maybe up to around 600 millimeter HT. This helps a bit, boosting both terms slightly.
But it's limited.
It's limited. The dissolved oxygen component, 0.003 millimeter Hg payloads, is still constrained by the maximum payload achievable at normal pressure. It increases, but maybe not enough in severe anemia.
Here's where the hyperbaric part becomes critical, right?
Precisely. Hyperbaric oxygen works by dramatically increasing the ambient pressure around the patient while they breathe 100% oxygen, usually in a specialized chamber. Increasing the ambient pressure proportionally increases the partial pressure of oxygen in the inhaled gas, and subsequently, the partial pressure of oxygen dissolved in the patient's arterial blood, the PAOs.
So instead of a PAO of maybe 500 or 600 on 100% oxygen at sea level,
when you're breathing 100% oxygen at, say, 3 atmospheres absolute pressure, that's roughly the pressure of 66 feet or 20 meters underwater, or about 304 kilopascals, the partial pressure of oxygen in your arterial blood can go dramatically, potentially over 2,000 millimeter Hg.
wow, over 2,000 millimeter Hg pair.
Yeah, and since the solubility constant, that 0.003 milliliter, is fixed, that huge increase in the millimeter Hg PAO term in the CaO formula causes a substantial, clinically significant increase in the dissolved oxygen component in the plasma.
So it's like taking that small sprinkling of dissolved oxygen we talked about and turning it into a torrential downpour capable of carrying a significant amount of oxygen on its own.
Exactly. That's the physiological power of HBO in this setting. At pressures around 3 atmospheres absolute, the amount of oxygen dissolved in the plasma alone, just the plasma, forget the red cells for a moment, can potentially supply the body's baseline metabolic needs, even if there's very little hemoglobin present to carry oxygen.
That's incredible. It bypasses the need for hemoglobin, essentially.
For baseline needs, potentially yes. And the sources reference a classic historical demonstration of this principle, Barima's experiment back in 1959.
Ah, the swine experiment.
That's the one. He took swine and intentionally exsanguinated them until their hemoglobin levels were incredibly low, between 0.4 and 0.6 grams per deciliter, basically living without functional red blood cells. Almost none.
Unbelievably low.
Yeah. When these animals were placed in a hyperbaric chamber at 300 kilopascals, around 3 ATA, and ventilated with oxygen, they were able to survive for a short period. This experiment profoundly demonstrated that dissolved oxygen at high partial pressures can indeed sustain life even when the primary oxygen carrier, hemoglobin, is almost absent.
That experiment really drives home the potential. So the core benefit, as presented in the sources, is that HBO provides a way in acute severe anemia to successfully correct the accumulating oxygen debt in patients who cannot receive transfusions or when blood isn't available. It buys crucial time for the body.
Buys time, reduces the debt, keeps tissues alive. Now, which organs are most vulnerable to inadequate oxygen delivery in severe anemia? Where does this increased dissolved oxygen matter most?
The sources highlight the 2 mammalian organ systems with the highest oxygen consumption rates.
Yeah.
The heart and the brain.
Right. They're the oxygen gluttons. The brain typically extracts about 6 milliliters of oxygen for every 100 milliliters of blood that flows through it.
6 milliliters per 100 milliliters for the brain.
And the heart muscle extracts even more, between 10 and 20 milliliters of oxygen per 100 milliliters of circulated blood, depending on how hard the patient's heart is working at that moment.
10 to 20 milliliters for the heart. Much higher.
Yeah. This high demand explains why clinical signs of severe anemia impacting these organs often appear first. Altered mental status from brain hypoxia, or ischemic changes on an electrocardiogram, maybe even chest pain from heart muscle hypoxia.
Makes sense. They feel the pinch first.
Exactly. So HBO's ability to dramatically increase dissolved oxygen can help ensure these critical, high-demand tissues receive enough oxygen to continue functioning, even when red cells aren't delivering their usual cargo. It keeps the lights on, so to speak.
Okay, so practically, how is this therapy administered? The sources describe intermittent hyperbaric oxygen as the clinical approach to rectify accumulating oxygen debt when transfusion isn't an option, not just one big dose.
Right, it's usually given in sessions. The parameters for treatment are outlined. Initial treatment pressures typically range from 2 to 3 atmospheres absolute, which is 202.65 to 303.98 kilopascals.
2 to 3 ATA.
Treatment duration can be up to 3 or 4 hours per session. That's quite a long time under pressure.
3 to 4 hours. And frequency.
Sessions can be administered frequently, especially early on, potentially 3 or 4 times a day.
3 or 4 times a day. Wow. That requires careful management.
It does. And a critical safety measure during these prolonged high-pressure oxygen exposures is the use of air brakes.
Air brakes. Tell me about those.
The patient periodically breathes regular room air for a few minutes, maybe 5 or 10 minutes, during the treatment session, while still under pressure. This helps reduce the risk of oxygen toxicity, particularly central nervous system toxicity, which could manifest as seizures. It breaks up the continuous high oxygen exposure.
Okay, so air breaks are essential for safety during long treatments.
Very important. The sources also mention the importance of the intertreatment interval, the time the patient spends at normal atmospheric pressure between the HBO sessions, the surface interval.
Right. Now, regarding how to guide the frequency and duration of treatment initially, what do the sources say?
Well, they suggest that the occurrence of end organ dysfunction clinical signs, like altered mental status, ischemic EKG changes, maybe diarrhea suggesting ischemic bowel hypotension, or diminished urinary output, may be used as initial guidance for how often or how long to treat.
Okay, so watch for signs of trouble and treat accordingly.
Yes, but they immediately caution against relying solely on this approach. They state that waiting for these signs is less desirable because their appearance indicates that the illness or injury caused by the severe acute anemia has already progressed to the point of causing organ damage. You're already behind the curve.
So ideally, you want to intervene before those signs appear or treat aggressively enough to prevent them.
That seems to be the implication. A more proactive way to guide treatment over time, according to the sources, is by using adjunctive hematinics.
Hematinics, like iron, B12, folate.
Exactly. Substances the body needs to make red blood cells. By giving these, often intravenously for rapid effect, you support the patient's bone marrow as it works to regenerate red blood cells. You're helping the body build its own supply back up.
So use HBO as the bridge, but actively work on rebuilding the patient's own hemoglobin at the same time.
Precisely. As the patient's own hemoglobin level gradually builds due to this regeneration, or potentially with the help of erythropoiesis-stimulating agents, the need for the high levels of dissolved oxygen provided by HBO lessens. The surface intervals between HBO treatments can then be gradually lengthened. Maybe go from 3 times a day to twice a day, then once a day, and eventually stop as the patient recovers. You're using HBO to bridge that critical gap until the patient's own red cell mass recovers, or other definitive measures, like successful hemostasis or even transfusion, if feasible later, are implemented.
This concept of intermittent oxygen exposure having beneficial biological effects, it isn't limited just to high pressure, is it? The sources mention something called the normobaric oxygen paradox.
That's right. They cite recent research showing that even intermittent short-duration breathing of 100% oxygen in normal atmospheric pressure, sometimes referred to as MBO, can have effects. For instance, doing this maybe every other day in healthy subjects was shown to increase hematocrit by increasing endogenous erythropoietin levels.
So pulses of normal pressure oxygen can stimulate red cell production. That's the paradox.
That seems to be the idea. The intermittent nature might trigger adaptive responses. And the sources note that there's increasing acceptance and updated information on using intermittent short-duration NBO in critical care settings for seriously ill patients too, not just healthy ones.
Interesting. So how does that relate to HBO?
Well, it contextualizes HBO. The sources state clearly that hyperbaric oxygen stands as a very useful bridge therapy in acute support of a severely anemic patient. It's like the most potent version of this concept of using oxygen administration to drive physiological benefits, particularly useful acutely when blood is unavailable or contraindicated, because it provides that immediate, massive boost in dissolved oxygen for tissue survival, while potentially also supporting longer-term recovery mechanisms.
Okay. Micro recap 3. We've detailed how HBO addresses inadequate oxygen delivery in severe anemia, primarily by dramatically increasing the dissolved oxygen in plasma, thanks to the high partial pressure of oxygen achieved under hyperbaric conditions.
The key mechanism.
We discussed how this dissolved oxygen can potentially meet baseline metabolic needs, referencing the historical Burema swine experiment. We highlighted the vulnerability of high oxygen demand organs like the heart and brain, and how HBO can help perfuse them.
Critical organs.
We covered the practical administration of intermittent HBO, pressures of 2-3 ATA, duration up to 3 to 4 hours, frequency potentially 3 to 4 times daily initially, the crucial need for air breaks for safety, and how to guide treatment ideally by patient improvement and hematinic response rather than just waiting for end organ damage.
Right. Proactive guidance.
Finally, we touched on the related normobaric oxygen paradox, showing how intermittent oxygen exposure has physiological effects even at normal pressure, which kind of reinforces HBO's role as a powerful acute bridge therapy in this context.
Excellent summary. So let's turn our attention now to the evidence supporting the use of HBO in severe anemia. as presented in the sources. They use established frameworks to evaluate this.
Right. They refer to widely accepted frameworks for guiding clinical interventions, mentioning the American Heart Association, or AHA, evidence-based criteria as an example.
Within that framework, they note that standard normobaric oxygen is considered a Class 1 indication, meaning strong evidence for effectiveness. It should be done. Standard care.
Class 1. Got it. And for HBO in severe anemia?
For hyperbaric oxygen in this specific context, the sources state it may be classified as a Class 2B indication according to AHA criteria.
Class 2B. Okay, what does that mean exactly in the AHA system?
Generally, Class 2B means the evidence is moderate, maybe based on single randomized trials or non-randomized studies. It suggests that the usefulness or effectiveness is less well established, and the benefit might outweigh risk, so it may be considered or could be reasonable. It's not a strong recommendation like Class 1, but it's definitely on the table as an option.
Okay, Class 2B moderate evidence may be considered. And the sources say animal studies support this?
Yes, they state that controlled animal studies provide support for this classification. The sources refer to a body of published animal experiments that have investigated HBO for severe anemia, and they summarize some of this work in a table. Table 1, apparently.
So what did these animal studies generally involve?
These studies, conducted in various animal species like dogs and rats, used different models of severe hemorrhage. Some used bleeding down to a predetermined low mean arterial pressure, often called the Weir's model, a classic shock model. Others used fixed volume blood loss, different ways to induce severe anemia and shock.
And the findings?
Across these different studies and models, the sources note a rather consistently observed finding. Significantly better survival rates in the animal groups treated with hyperbaric oxygen compared to control groups treated with just normobaric air or even normobaric 100% oxygen.
Consistently better survival. Can you give an example from the table they described?
Sure. The verbal description mentions a study by Attar in 1962 using an intravascular hemolysis model in dogs. In that study, survival was only 20% in the normobaric air group after 2 hours. But the group treated with HBO at 0.2 megapascals, about 2 ATA, for 120 minutes had a striking 96% survival rate.
Wow, 20% versus 96%. That's a huge difference.
It is. Another example mentioned is by TRALI in 1965 using the Weir's low blood pressure model in dogs, only 17% survival at 48 hours in the normobaric air group, compared to 74% survival in the HBO group treated at 0.3 megapascals 3 ATA for 150 minutes.
Again, a massive difference, 17% to 74%.
Yeah. And similar dramatic differences were apparently seen in other studies referenced in the table, like Blair in 1964, hemorrhagic shock, 10% to 73% survival. And another Cowley study in 1965, Weir's model, maybe different parameters, 17%, 74% again. The sources emphasize this consistent finding of significantly improved short-term and long-term survival with HBO in these animal models.
And the evidence grading for these studies in the table.
The verbal description notes the table often assigns an evidence grade, like Class 2B, to these individual animal studies, which aligns with the overall AHA classification mentioned earlier for HBO in severe anemia. So these experimental studies provide strong, reproducible evidence in controlled settings that HBO can mitigate the lethality of severe oxygen-carrying deficit.
Okay, so strong animal data. What about human evidence?
Beyond the animal work, the sources state that published human case reports and case series also provide evidence and allow for similar evidence-based acceptance, although acknowledging this is inherently a lower level of evidence compared to controlled trials. This human experience is referenced in another table, Table 2.
Table 2. Human cases. What kind of information is in there?
This table apparently summarizes various human experiences using HBO for severe anemia in real-world clinical situations. It includes details like patient age and gender, the clinical scenario, things like massive GI bleed, post-surgical bleeding, trauma, autoimmune hemolytic anemia, AIHA, antepartum hemorrhage, a range of causes. It also quantifies the severity, the admission hemoglobin or hematocrit, often incredibly low values. It notes associated clinical signs like altered mental status or hypotension. It mentions if other treatments like Hematinics were used, details about the HBO administration, pressure, duration, frequency, and crucially, the survival outcome.
Can you give some examples of the severity from these case reports, just to illustrate the kinds of patients we're talking about?
Sure. The description mentions cases like an admission hemoglobin of just 1.5 grams per deciliter with altered mental status, it's incredibly low. Another with HB 2.6 GDL with hypotension and altered mental status from diverticular bleeding. A patient with autoimmune hemolytic anemia failing steroids with an HB of 3.8 GDL. A case of antepartum hemorrhage presenting with a hematocrit of only 2%, which corresponds to an HB less than 1 GDL.
Wow. These are patients really on the absolute edge of survival. It's hard to imagine surviving those numbers without intervention.
Exactly. And the table shows examples of patients in these extreme circumstances who were treated with serial HBO sessions, often along with hematinics and other supportive care, sometimes eventually getting transfusion after stabilization or if bleeding continued, and who survived.
So despite being a lower level evidence.
Right. Case reports and series are typically graded lower, maybe level 3 evidence, meaning based on descriptive studies or expert opinion. But they demonstrate that in these specific challenging situations where conventional therapy is limited or refused, survival has been observed with the use of HBO. They provide real-world clinical examples that align with the physiological rationale and the animal data. They show it can work in humans in dire straits.
Okay, so animal data is strong, human case reports are illustrative. Is there anything stronger in terms of human evidence?
Yes. The sources don't rely solely on those. They mention a recent controlled prospective human trial. This is a higher level of evidence.
A prospective trial, what did it involve?
This trial involved postoperative patients undergoing partial hepatectomy liver resection for liver cancer, a very specific, high-risk surgical population.
Okay. And the intervention?
The intervention was using postoperative hyperbaric oxygen with a stated goal of restricting red blood cell transfusions in these patients. They compared an HBO group, N20, to a non-HBO control group, N21.
And the outcome?
They found improved survival in the HBO group compared to the control group.
Improved survival in a prospective human trial. That's significant.
It is. And the suggested mechanism from this trial, as highlighted in the sources, is that acute HBO after hepatectomy, used specifically to reduce the need for transfusions, may effectively overcome deficiencies in oxygen supply, both systemically and specifically to the remaining liver tissue. This could diminish postoperative complications and improve outcomes.
So this study provides stronger prospective human evidence supporting the use of HBO in a specific surgical context where limiting transfusion is considered beneficial.
Correct. It adds another important piece to the puzzle.
Okay. So bringing all this evidence together, the animal studies, the human case reports, this prospective trial, what's the overall conclusion from the sources?
The sources conclude that, based on both the consistent support from animal work and the accumulation of human clinical experience, from cases up to that prospective trial, evidence-based analysis firmly supports the use of hyperbaric oxygen as a treatment option in severe anemia. They mentioned the support aligns with criteria used by frameworks like the AHA, the National Cancer Institute Physician Data Query, NCIPDQ, and the British Medical Journal.
So despite the overall AHA classification perhaps being Class 2B.
Right, which means moderate evidence, reasonable to consider. The diverse lines of evidence presented, especially the dramatic and consistent survival improvement seen in controlled animal studies, the illustrative human cases of survival in otherwise likely lethal scenarios, and the positive prospective trial make a compelling argument for its utility in these specific transfusion-limited circumstances.
Okay. Micro recap 4. We've reviewed the evidence base presented in the sources. Animal studies consistently demonstrate significantly improved survival in models of severe hemorrhage when treated with HBO, providing strong experimental support. Human case reports and series, while lower-level evidence, provide clinical examples of survival in individual patients with extremely low hemoglobin treated with HBO when transfusion was challenging or refused.
Illustrative, yeah.
A recent controlled prospective human trial in hepatectomy patients adds higher-level evidence supporting HBO in a specific surgical context aimed at reducing transfusion.
Important addition.
This cumulative evidence, spanning different study types and levels, supports HBO as a valid treatment option in severe anemia, aligning with an American Heart Association Class 2B indication moderate evidence, making it reasonable to consider.
That sums it up nicely. Now let's move into the practical aspects of actually utilizing hyperbaric oxygen in severe anemia, based on the source's guidance. When exactly should it be considered?
The sources reiterate the specific clinical situations we've discussed. Patients who cannot receive blood products due to medical reasons like antibodies, religious beliefs, or strong personal preferences. Or simply when blood is unavailable in a timely manner in an emergency, the cannot or will not transfuse scenarios.
Right. And how should its use be guided? What triggers the decision to start HBO?
The sources are quite clear on this. It should primarily be guided by the presence of clinical signs or symptoms indicating systemic or individual end organ failure due to inadequate oxygen delivery.
So look at the patient. Are they showing signs their organs aren't getting enough oxygen?
Exactly. Think altered mental status, chest pain or ischemic EKG changes, signs of gut ischemia like that sprue-like diarrhea mentioned, declining kidney function or low urine output, persistent hypotension despite volume. Those kinds of clinical signs.
Okay, clinical assessment is key. Now, crucially, the sources explicitly state which should not be used as the primary driver for initiating HBO. What was that?
Calculating the patient's accumulated oxygen debt.
Right, even though we discussed the concept of oxygen debt and its prognostic importance.
They say you shouldn't try to calculate it at the bedside to decide whether to start HBO. Why not?
The reason given is purely practical. Calculating that precise oxygen debt isn't readily available at the bedside in an acute emergency. It requires measurements like mixed venous oxygen saturation, cardiac output, etc., which might not be immediately obtainable or reliable in a crisis.
Makes sense. So while the concept of oxygen debt explains the underlying problem and the urgency, the clinical decision-making for starting HBO should be based on observable, rapidly assessed signs of organ dysfunction indicating the patient's tissues are failing to get enough oxygen right now.
Exactly. Look for the clinical evidence of inadequate oxygenation. And the sources position HBO fundamentally as a bridge therapy.
A bridge, meaning temporary.
Yes. It's meant to stabilize the patient and provide adequate oxygenation during the acute, life-threatening phase of anemia until the underlying cause can be resolved.
And resolution might involve
achieving surgical or medical hemostasis to stop bleeding, administering therapies to stop rapid red blood cell destruction if hemolysis is the cause, or potentially administering blood products later if the patient's status changes, the reason for refusal changes, or if transfusion becomes possible or necessary after stabilization. HBO buys time for those definitive treatments to work or become feasible.
Okay. In terms of practical administration details, the sources note that hyperbaric oxygen can be administered rapidly once the patient is actually in a hyperbaric facility and ready to go.
Right. The treatment parameters, as we mentioned before, pressure is typically up to 200 to 300 kilopascals, which is 2 to 3 atmospheres absolute.
2 to 3 ATA.
Each session can last 3 or 4 hours.
Long sessions.
And in severe acute situations, sessions can be administered frequently 3 or 4 times a day, provided those intra-treatment air breaks are used diligently to prevent oxygen toxicity.
Air breaks again, absolutely essential for safety with these protocols. The patient breathes room air for a short period intermittently during the oxygen exposure.
Correct. And along with the HBO treatments themselves, the sources emphasize the crucial importance of co-administering hematinics.
Right, the building blocks. Intravenous iron, vitamin B12, folic acid. Support the bone marrow.
Exactly. Get the patient's own factory working. Nutritional support is also mentioned as vital, ensuring the body has the energy and protein needed for red blood cell production and overall recovery. You can't build bricks without straw or protein and calories.
Good point. Now, how do you decide when and how to taper or stop HBO treatments?
The sources suggest continuing HBO, but gradually tapering both the duration of individual treatments and the frequency of sessions, the surface interval, as the patient improves.
An improvement is judged by
the patient's clinical status, resolution of those end organ dysfunction signs, and evidence of red blood cell recovery, seeing the hemoglobin and hematocrit levels start to rise, either through their own regeneration stimulated by the Hematinics, or if the patient's condition changes and they eventually accept or receive transfusion. You wean the HBO as the underlying problem gets fixed.
Okay, that makes sense. The sources also provide a helpful management algorithm summarized in a flowchart, figure 1 apparently, illustrating the decision pathway for severe anemia, particularly showing where HBO fits in. Can you walk us through the key points of that flowchart?
Conceptually, yes. It starts with the recognition of severe anemia. The overarching goal, stated again, is successful shock resuscitation and stabilization, bridging the patient until definitive therapy like hemostasis, stopping hemolysis, or transfusion is achieved.
Okay, then criteria for considering HBO.
The flowchart apparently lists criteria like an initial shock index greater than 1. That's heart rate divided by systolic blood pressure, a quick indicator of shock severity. Also, active or uncontrolled life-threatening bleeding.
Active bleeding, shock index 1, what else?
Or a specific hemoglobin level less than 10 grams per deciliter if there's evidence of critical organ ischemia, like myocardial infarction, gut ischemia, spinal cord ischemia, or brain ischemia.
Interesting. That threshold of 10 GDL for specific organ ischemia is higher than the 6 or 3.6 GDL thresholds for overall problematic or inadequate delivery we discussed earlier.
Right. It highlights the increased vulnerability of these vital organs. They might need more oxygen, so the threshold for concern is higher. Clinical suspicion of an accumulated oxygen debt is also listed as a criterion, though, as we discussed, that's harder to quantify readily at the bedside.
Okay, so if those criteria are met,
The next step is crucial. Assess if the patient is medically clear for HBO therapy. Are there contraindications like an untreated pneumothorax or certain medications?
right, safety check, if they are clear.
Then the chart emphasizes standard critical care initial preparation, ABCs or maybe CAB these days, airway breathing, circulation according to established protocols like ATLS or ACLS. Stabilize the patient first.
Basics first, then initiate HBO.
Yes. Initiate HBO therapy with continuous monitoring. The chart specifies monitoring parameters including capnometry, end-tidal cooro reflecting perfusion, blood pressure, pulse oximetry, and continuous EKG monitoring to watch for improvement or worsening of organ ischemia or heart strain.
Close monitoring during the treatment.
Absolutely. And then there's a loop. Titrate the HBO treatment parameters, the pressure, table depth, the length of the session, and the interval between sessions based on the monitored physiological signs. Watch the patient, adjust the therapy, then reassess.
A continuous adjustment process, what about outcomes?
If symptoms resolve. The flowchart suggests you can hold HBO therapy, but it adds an interesting nuance. Consider continuing treatments even after initial resolution if there's clinical suspicion of multi-organ reperfusion injury.
Reperfusion injury. So HBO might help mitigate damage when blood flow returns.
That's the suggestion. It points to potential benefits of HBO beyond just acute oxygenation, possibly related to reducing inflammation or oxidative stress associated with ischemia reperfusion. It's an interesting point.
What if the criteria aren't met, or the patient isn't clear, or they don't improve?
The flowchart also shows alternative paths. Reconsider HBO if something changes, pursue conventional 1 atmosphere, critical care, manage supportively, and constantly reassess the situation. It provides a structured framework for thinking through the options and integrating HBO appropriately.
Very helpful. Now, from a practical standpoint, the sources also touch on the cost and safety of HBO. What do they say about cost?
They state that the cost of a single hyperbaric oxygen treatment is comparable to the cost of 1 unit of packed red blood cells in the Western world.
Comparable cost to a unit of blood. That's useful context, especially if you're avoiding multiple transfusions.
Exactly. It makes it a relatively cost-competitive option in these specific challenging scenarios where multiple units of blood might otherwise be considered necessary over a short period.
And regarding safety,
the sources note that side effects of HBO are few and infrequent when administered appropriately with those crucial air breaks and proper patient selection and monitoring. Things like middle ear barotrauma can occur, but are usually manageable. CNS oxygen toxicity is rare with current protocols. The overall safety record of hospital-based HBO in the United States has been very good to date.
good safety profile, cost comparable. Okay. Micro recap 5. We've covered the practical aspects of HBO utilization in severe anemia. We discussed when to consider it primarily when transfusion is not possible due to patient factors, medical reasons, or unavailability.
The key indications.
We emphasize guiding its use by clinical signs of end organ failure, not by complex oxygen debt calculations at the bedside.
Clinical judgment first.
We reviewed the practical administration details. Pressures up to 3 ATA, durations of 3-4 hours, frequency up to 3-4 times daily initially, the crucial use of air breaks, and the need for adjunctive hematinics and nutritional support.
The how-to.
We describe the general flow of the management pathway outlined in the source's flowchart, highlighting criteria for use, preparation, monitoring, titration, and tapering.
The algorithm.
Finally, we noted the relatively favorable cost comparison to packed red blood cells and its good safety profile.
Putting it all together practically.
Yeah.
Okay, let's consolidate our understanding now with a summary of the key points from the sources and maybe look towards future perspectives.
That's good. Let's reconfirm the core mechanism first.
Right. Hyperbaric administered oxygen works in severe anemia by dissolving a significantly increased concentration of oxygen directly into the red blood cell poor plasma or even into the crystalloid colloid fluids used for volume resuscitation. This dissolved oxygen becomes the primary means of oxygen transport to tissues when hemoglobin is critically low.
Bypassing the hemoglobin deficit.
Essentially, yes. The sources also briefly touch on a potential longer-term benefit again. In patients with less acute, maybe chronic or subacute anemia, pulsed Intermittently provided normobaric oxygen or even hyperbaric oxygen can actually induce an increase in their red cell and hemoglobin mass over time.
That normobaric oxygen paradox idea, again, possibly stimulating erythropoiesis.
Seems to be the connection, yeah. Leveraging biology beyond just the immediate oxygen delivery. Now, the sources offer a perspective on conventional transfusions again in the summary.
What's the phrasing there?
They state that transfusions of separate donor red blood cells are, quote, transplantations of tissue not uncomplicated by immunomodulatory reactions.
A stark reminder, it's a transplant with potential immune consequences.
Exactly. This frames homologous, or donor, packed red blood cells as carrying potential risks beyond just infection or fluid overload. While HBO isn't an autologous patient's own blood product, the sources suggest that therapies that reduce reliance on homologous transfusions, whether that's using autologous blood when possible or a bridge therapy like HBO, may be less problematic in the long term, especially regarding immune effects and maybe even overall oxygen debt reduction compared to just pouring in donor cells.
Interesting perspective. The sources then emphasize HBO's decisive role in reducing oxygen debt in what they call polar clinical extremes.
Polar extremes.
Yeah.
Yeah, they describe these ranging from situations of near exsanguination with cardiopulmonary arrest, where every single molecule of oxygen delivered matters immediately,
Life or death seconds.
all the way to the resuscitation of severely anemic patients who, for strong reasons, religious refusal, immunologic incompatibility, or just lack of blood availability, simply cannot receive red blood cell transfusions. In these critical moments, HBO can make a life or death difference by ensuring vital oxygen delivery when no other option exists.
A true lifeline in those situations. The point about cost is reinforced in the summary, too, isn't it?
Yes, mentioned again, an HBO treatment is equivalent in wholesale cost to a unit of packed red blood cells in the Western world. They summarize it as a relatively low technology, cost-competitive means of pharmacologically reducing accumulated oxygen debt in an anemic, injured, or critically ill patient with very few side effects when used appropriately.
Low-tech, cost-competitive, safe option in specific contexts. What about the future?
Looking ahead, the sources speculate that the future may well see broader use of hyperbaric oxygen in a variety of acute care settings.
Where specifically?
They list potential settings like military far-forward environments, maybe pre-hospital emergency medical services settings, trauma center emergency departments, operative and recovery units, and intensive care units within hospitals. Basically, anywhere you might encounter acute, severe anemia where transfusion might be delayed, difficult, or contraindicated.
So expanding its reach in emergency and critical care.
That seems to be the potential envisioned. And crucially, the sources highlight again that HBO provides availability as a bridge therapy, specifically designed to avoid the dangers associated with administering multiple units of blood, hastily, maybe emergency release blood, to a patient with severely inflicted anemia, whether from medical causes, surgery, or trauma.
Avoiding the risks of massive transfusion.
Right. And having used HBO as a bridge to stabilize the patient, maybe get them through the initial crisis, it then becomes possible, as the sources note, to consider a more measured administration of blood products in lesser quantities later on, if transfusion eventually becomes an option or necessary. The HBO treatment has bought time, improved the patient's oxygenation status, and may be allowed for more definitive cross-matching or just reduce the total volume needed.
So it facilitates safer transfusion practices if transfusion is ultimately used.
That's the idea. Finally, the sources make a really key observation that underscores the importance of this deep dive, I think. They state that hyperbaric oxygen is, quote, still often missing in current articles on oxygen delivery in severe anemia.
Missing, despite the evidence and approval.
Apparently so. This implies it's a recognized, approved, evidence-supported option that just isn't being discussed or considered as widely in the literature or perhaps in clinical practice as it maybe should be. It's underutilized or overlooked.
Interesting.
And the source's concluding sentence is really a direct call to action for clinicians like you, the listener. Hopefully, consideration of use of HBO will gain increasing noticeability of physicians.
So this deep dive is part of that effort, raising awareness, increasing noticeability about this valuable tool in a challenging clinical scenario.
Exactly. Getting it onto the clinical radar. Okay, let's do the end of chapter mega recap. We've taken a really comprehensive deep dive into severe anemia and the critical role of hyperbaric oxygen when conventional transfusion is not possible.
We started by defining the physiological problem, marked red cell loss leading to inadequate oxygen carrying capacity. We explored the key formulas for oxygen content, COOers, remembering hemoglobin bound versus dissolved, oxygen delivery, DO euros in oxygen consumption. VO euro equals COX AVO diff. We highlighted the difference between hemoglobin bound and dissolved oxygen and emphasized the crucial hemoglobin thresholds: 6 GDL problematic, 3.6 GDL inadequate, and the accumulated oxygen debt thresholds, 9, 22, 33 LMs, that predict patient outcomes.
Got the physiology down. Then we examined the significant clinical challenges that prevent transfusion, patient refusal, religious personal, cross-matching issues, TTI concerns, however small, and the serious complications of massive transfusions like TRALI, TAD, and TACO, plus immunomodulation.
Right, the reasons we need alternatives. This led us to hyperbaric oxygen therapy as an established CMS-approved bridge therapy explicitly noted for avoiding these complications.
Then we detailed how HBO works physiologically, by dramatically increasing dissolved oxygen via high partial pressures, compensating for low hemoglobin. We referenced the historic Boehringer experiment and noted HBO's importance for high-demand organs like the heart and brain.
The mechanism and target organs. We covered the practical aspects of administering intermittent HBO, treatment parameters, 2-3 ATA, 3-4 ATers, 3-4 day initially, the absolute need for air breaks, the importance of adjunctive hematinics and nutrition, and guiding treatment based on clinical signs, not O2 det calcs, as outlined conceptually in the management flowchart.
How to actually do it. Then we reviewed the evidence base. Consistent survival benefits in animal hemorrhage models, illustrative human case reports showing survival in dire situations, and a supportive prospective human trial in hepatectomy patients. We acknowledge this cumulative evidence supports an AHA Class 2B indication moderate evidence reasonable to consider.
The evidence pyramid. And we concluded by reiterating HBO's mechanism, its cost comparability to packed cells, its good safety profile, its decisive role in clinical extremes, its potential for broader future application in acute care, its value as a bridge therapy, avoiding massive transfusion dangers or enabling more measured transfusion later, and echoing the source's call for increased physician awareness of this often overlooked therapy in severe anemia management.
Phew. That was a deep dive indeed. We've covered a significant amount of ground, unpacking the complexities of severe anemia, the limitations of conventional approaches, and the detailed physiological basis, evidence, and practicalities of hyperbaric oxygen as a critical bridge therapy, all drawn directly from the source material provided.
This really provides a solid foundation, I think, for understanding when and how to consider this potentially life-saving therapy in those incredibly challenging scenarios where transfusion just isn't a readily available or acceptable solution.
Agreed. It equips you with the knowledge to have it in your armamentarium.
So building on everything we've explored today, the clear physiological mechanism of boosting dissolved oxygen, the consistent animal data showing survival benefits, the compelling human case reports in dire circumstances, the positive prospective trial data, the manageable safety profile, and the practical benefit of avoiding the risks of massive transfusion. Here's a final question for you, our listener, to reflect on in your own clinical practice.
Given this evidence base, particularly that American Heart Association Class 2B classification moderate evidence, may be considered, how does hyperbaric oxygen therapy fit into your personal decision-making algorithm when you're faced with that critically anemic patient for whom conventional transfusion is not an immediate or viable option? What piece of information shared today resonates most strongly with you as you consider this therapeutic tool for those specific difficult cases? Something to think about until our next deep dive.